Hi there, I'm Dr. Tara McCannel, and I'd like to welcome you to today's webinar. If you'd like to ask questions about any of our content, please feel free to send in your questions. So today I'm going to speak with you about the new treatments in ocular melanoma at UCLA. And before I begin, I just want to acknowledge some very important people that I work with. Dr. Mondino is our chairman. Dr. Sada is our president at the Doheny Eye Institute, also part of UCLA. Dr. Bradley Stratsma, who founded the Jules Stein Eye Institute, and members of our ophthalmic oncology team, as well as members of our radiation oncology team, and members of our hematology oncology team. All these individuals help look after our patients. So today I'm going to speak with you about the following topics. We're going to review some basics about ocular melanoma. Then I'm going to go into some of the new surgical treatments and strategies that we are working on and offering to patients here at UCLA. We're going to talk about treating small melanomas. We're going to talk about how we have eliminated the second procedure in treating melanomas so that we can take out the treatments in our office. I'm going to talk to you a little bit about cataract and vitrectomy. These are surgical procedures that happen at the time of melanoma treatment. And I'm going to talk about how we can treat retinal detachment, which is a part of melanoma, at the time of the surgery. So what is ocular or uveal melanoma? Melanoma, much remains to be understood, but this is not known to be a hereditary cancer. It is often associated with other cancers. It originates from pigmented cells in the uvea, and this term uvea refers to iris, ciliary body, and choroid, which are parts of the eye which are related. Uveal melanoma is detected on a routine eye exam, or sometimes the tumor itself can cause symptoms for the patient, such as blurry vision or flashes of light. And sometimes a person may have a known freckle or nevus in the eye from which the melanoma may start to form. So just to review some basics about our ocular anatomy, this is a schematic of a normal human eye. In the front, we have the cornea, which is the clear surface, and the lens, which is here. This is what forms a cataract, and all the space behind we call the posterior segment. And melanoma usually forms in the posterior segment of the eye. Here's the retina, which lines the back of the eye wall like film in a camera. So in an eye with a melanoma, we often see the tumor starting from pigmented cells in the choroid. So here is where a representative location may be where a melanoma may form, just so you have an idea in the whole eye where the melanoma may be. Here's an eye that was removed from a patient who had a large melanoma. You can see the melanoma looks very light and like a mushroom shape in the back of the eye. And there's also the retina is detached, and we often see retinal detachment when there is a melanoma in the eye. And here's some photos that I've included so that you can get an idea of the variability of appearance of melanoma of the eye. You can see these three are melanomas inside the eye, and here is an example of an iris melanoma, a much more rare form of melanoma of the eye. So what are the effects on patients? Why is melanoma important? Well, for two major reasons. Melanoma can cause visual loss from the tumor disrupting the eye, or from retinal detachment, and more importantly, after we treat the melanoma, from the side effects of our treatment. And the second, and probably most important effect that melanoma has on patients is the risk of death from spread of the cancer, and we call that metastasis. And if you look at every single patient with a melanoma, we think that approximately half of those people may develop metastatic disease in the future. Ocular melanoma, if it does spread, tends to go to the liver. And it's important to know that it's rare to have spread of the cancer at the time the eye tumor is diagnosed. So just a little bit about ocular melanoma metastasis. There are two major risk factors that are associated with whether a tumor in the eye will spread in the body. One is tumor size. We know time and time again that the smaller the tumor, the better the prognosis for the patient. So a person with very large tumor has a higher risk of getting cancer spread. And the second, more recent discovery in the last several decades is that there are markers in the tumor from the tumor biology that can indicate to us whether a melanoma has the risk of spreading. And the first that was discovered was a loss of chromosome 3. We call that monosomy 3. And this is the strongest risk factor associated with metastasis or spread of the cancer. We can also do other testing where we can group the tumors into class 1, which is a good prognosis, or group 2, which is a poor prognosis. And we can determine these markers from doing a tumor biopsy, which is an important part of how we manage our patients. So let's talk about the first surgical topic that I wanted to share with you. This is to do with treating small ocular melanomas. This is a controversial area because until recently, most of the recommendations for people with small melanomas in the eye was for observation only. There was the feeling that these tumors may be observed and we don't need to treat them with radiation, or perhaps we could just monitor the patients and not offer treatment initially. Most of the melanomas that are small are actually near the macula, which is the center part of one's vision. And they start causing visual symptoms, and that's how they come to our attention. And they are so small because they're identified early because they start to affect the vital structures of the eye, mainly central vision. So the reason people may be reluctant to treat these tumors is because of fear of our treatments. We use radiation to treat melanomas in the eye for the most part, and there's a worry that if we radiate the center of the vision, the patient will be immediately blinded. Many times, it is often recommended that these small tumors the eye be removed entirely in order to avoid this potentially blinding complication. And also we know, I mentioned before how tumor size is important in prognosis. People know that the risk of metastasis is low for small tumors, so perhaps it is okay just to monitor and not treat them. So this is why treating small melanomas is somewhat controversial. However, there are benefits in treating small melanomas. And the reason there are benefits is that the smaller the tumor, the less radiation we need to use. And also, treating the smallest of ocular melanomas may influence mortality more than tumors that are already large, that have already micrometastasized, or where cells have broken off and are lodged in the body. And if we observe the tumor, if it's a melanoma, it will eventually grow. And then we're going to need more radiation to treat this, and certainly when we have to use a lot of radiation in the central vision, we're going to lose vision and have a poor visual outcome. So I want to share with you some examples of small melanomas that we have treated and that have done very well. This is a 55-year-old female who presented with 20/40 vision and a very small melanoma, 1.8 millimeters. And here is her. This is an example of the fluorescein angiogram, which shows activity of the tumor, and you can see this white area here. And this is another test that we often use called ocular coherence tomography, and this test actually identifies a second area that doesn't show up on our clinical exam. So we treated all of this, and it is very small, and 2 years later, her vision is about 20/50 after using radiation treatment. And she's doing very well with her eye. And this is a patient from many more years ago. Again, a 52-year-old female with pretty good vision. She started to have a change in her acuity, and again, a small melanoma. And it may be difficult to see on here. The melanoma is there. And here's her 8 years later, and her vision is 20/40, and she has good tumor control. And here we can see the OCT, or the scan, the cross-section through her central vision, and all the layers look very intact, and she's doing very well as well. So there's a lot of benefits if we can treat these early so that people don't develop serious blinding radiation retinopathy. So I mentioned that we use biopsy to get molecular information from melanomas so that we can understand a patient's prognosis with this cancer. And in very small melanomas, it is still somewhat controversial to proceed with biopsy because the tissue yield may be so small given the very small amount of tumor actually present. So what we can do is we actually use surgical instruments that have been developed in vitreoretinal surgery that allow us to obtain very small samples of tissue that is very safe, even from the very smallest of tumors. And here's an example. This is a 82-year-old male, and this is a lesion that's only 1.36 millimeters, and the melanoma is this darkened and light area on the photograph, and you can see an ultrasound that shows the height. This is a cross-section through the tumor showing fluid leaking from the tumor, which indicates activity. And here's a surgical video that shows how this is done. And this instrument is a 27 gauge vitreous cutter that we used for vitrectomy surgery. And the diameter is 0.4 millimeters, so it's very, very fine. And it can go right into the tumor, and a small sample is taken, and we can use that for testing to figure out how aggressive this particular melanoma is. And here's an example of another small tumor that's biopsied in a similar way, and oftentimes we may get a little spot of blood over the tumor, and within a month this usually disappears and does not have any consequence on the vision. So I want to talk to you about another development that we're very excited about at UCLA. When we do melanoma treatment, we use radiation, and the commonest way that radiation is delivered is using an iodine-125 plaque, which has the iodine-125 seeds of radiation. And here's a picture that was taken during surgery. You can see this is the plaque. It's gold on the outside to keep radiation from passing through externally. And usually when we do this, there's two surgeries. One is to put in the treatment that's going to kill the tumor, and then the patient requires a second surgery to remove it. And this may be done under local or general anesthesia. And in the last several months, we have developed a different way of attaching the plaque to the eye so that we don't have to take the patient back to the operating room for removing it. And I'm just going to share with you, this is very new, and how we do this. So this is the plaque, and this is sort of a cartoon to give you an idea how it works. And we use these sutures. Vicryl is a term for a type of stitch that we use, and we thread our sutures through the eyelets, these circles in the plaque, and then we put in a proline, which is another type of suture that's heavier, and we kind of anchor the whole thing with this proline, and we tie the vicryl sutures and include this piece of proline stitch. And once the tumor time for treatment of the plaque is complete, this is one thing, we attach a thread to the center of the plaque, so it's sort of the line that we can pull it out with. So when we're finished the treatment, we take out the proline, and we pull out the plaque, and these will dissolve on their own. So they can be left in the eye, and they will eventually disappear. And this way, we can have patients come to our office and remove the plaque in a very minor procedure that takes literally 5 to 10 minutes or less. So we've avoided taking the patient for a whole nother operation. I'd like to also talk to you a bit about cataract surgery and vitrectomy surgery at the time that we treat ocular melanomas with plaque. So one of the things that we do at UCLA, which is very unique in our ocular melanoma program, is that we use a substance in the eye during our radiation treatment which lowers the amount of radiation that affects healthy tissues in the eye. And this is using silicone oil. And what it does is it reduces radiation to the tissues that are not melanoma. We actually see less radiation retinopathy than in people who undergo standard plaque treatment. And we've also looked at our data where we have to use a lot of radiation, and certainly in people with large melanomas in a short amount of follow-up, we see significantly improved vision and lower numbers of people with poor vision. So just to give you an idea what this means, if this was an eye, and the brown spot on the eye is the melanoma, and you can see the iodine-125 plaque on the outside of the eye treating the melanoma. To treat the tumor, there are extraneous rays of radiation that do affect the non-tumor parts of the eye. Now, if we could fill the cavity of the eye, we could fill the vitreous humor with a substance that can reduce or block the radiation, then we can still treat our tumor properly and minimize the damage that happens to the rest of the eye. So this is in fact what we do at UCLA, and this is an option for patients undergoing treatment. And initially in 2010 we demonstrated this property of silicone oil, and I should mention that silicone oil is a substance that we use frequently when we treat retinal detachments, and it's also very useful in this situation. And we looked at our first series of patients, of all comers, and compared them to patients who didn't have this silicone oil treatment, and we found there was less radiation retinopathy. And then most recently we've looked at very large tumors which tend to do very poorly regardless of what type of treatment we use, and with silicone oil they do much better with better final vision. And these are just our publications that indicated these discoveries. And this is a sample of some data that is not published yet, but just as it includes all of our very large tumors. And the blue bars represent people who underwent plaque treatment alone in a standard way, and the red bars represent people who have undergone plaque surgery with vitrectomy and silicone oil placement to help shield the radiation. And I've divided the outcomes into two groups, one with good vision, so people who are better than 20/40, better than 20/80, and better than 2200. You can see that there are more numbers of people who underwent the silicone oil that do better. And then if we group the people into poor vision outcomes, those with vision worse than 2200 and those who have light perception or no light perception, which is totally blind, you can see that the red group, which is the vitrectomy with silicone oil, do far better. We have far fewer of those poor outcome eyes. So this is a very useful way that we can eliminate or reduce the radiation up front. The ways that we deal with the side effects of radiation now are mostly after the radiation has caused the damage. And there are many things that can be done to help even then, but this is a way we can get at the radiation ahead of time. So here's an example of an eye that is undergoing cataract surgery. This is the implant that goes in place, and then we put a suture on the outside. And then this is the plaque that has already been placed and positioned, and then these instruments here are micro-incisional vitrectomy ports that allow us to go into the eye. And you can see on the side here is the melanoma, and this little silver probe is the vitreous cutter, and that's removing the vitreous humor from the back of the eye. And we're very careful to get as much as we can away. And the reason we recommend cataract surgery as an important tool is that cataract surgery can remove the natural lens and allow more space for us to clear out the vitreous, to put in silicone oil, and also it avoids the patient needing to have cataract surgery shortly thereafter, as a patient who undergoes a procedure with vitrectomy and oil will almost always develop a cataract in the near future. So we can minimize things and make things a little convenient for the patient as well as optimize our treatments. So let's talk a little bit about repairing retinal detachment at the time that we treat melanoma of the eye. Retinal detachment is almost always present when we have a melanoma in the eye. The larger the melanoma is, the more extensive the retinal detachment is. And if we just leave the retinal detachment, and particularly if the center of the vision is involved, so the retina is detached over the macula, then vision outcome is usually poor because anatomically the layers of the retina are not opposed to the back of the eyeball where they need to be for proper nourishment. And whenever we have a retinal detachment with a melanoma, typically we call this a serous or an exudative detachment, and the detachment is there because there's a tumor. And these retinal detachments often, frequently are neglected because they're considered a medical problem. When a person walks in and suddenly their retina detaches, that person has usually emergent surgery and the retina is repaired so that the person can see as best as possible. However, in a situation where there's a melanoma with a big retinal detachment, people are not treating the situation as urgent as they would a more typical type of retinal detachment. So usually there is no attempt made to address repairing of these retinal detachments. So this is an example of what a retinal detachment looks like in an eye with melanoma. So on this side is actually the tumor, and it looks very similar, partly because of our photograph, but this is the tumor underneath this bulge. And everything else and everything to the side here is actually retinal detachment. So again, this is quite a large tumor and there's quite a bit of retinal detachment present. So why could we treat this exudative retinal detachment up front? Another benefit for getting rid of the detachment is we can make room in the vitreous cavity to add more silicone oil to help attenuate or shield the radiation from affecting the healthy tissues in the eye. And the second reason, which I alluded to, is that we can get the macula and parts of the retina to be reattached by this oil bubble. And silicone oil, as I said before, is used frequently to fix retinal detachments. So it can also be used, in addition to blocking radiation, it can be used to help repair retinal detachments in eyes with melanoma. So if we can get everything attached, especially the central vision, that person is going to end up with much better vision than if the retina remained detached for the whole time. And then there are other reasons why it is helpful to get rid of the retinal detachment. If we just leave the detachment present, which we have done in the past, we actually can get some complications if we just leave the fluid there. And sometimes you can get chronic scarring and the tissue can contract underneath chronic subretinal fluid, which is the fluid from the retinal detachment. So this is an example of we have a lot of retinal detachment. It's very hard to put much silicone oil in that eye. So if we could fill up the eye with more silicone oil, then we could do more shielding of the radiation with this vitreous substitute. So retinal detachment, let me just move forward here. So let me tell you about this technique of draining from the outside. And this is how we attempt to remove and treat retinal detachment in eyes with melanoma. We do this sometimes in conventional retinal detachment surgery, but most of the times for conventional retinal detachment, we actually drain the fluid from inside. In an eye with a melanoma, less is more, so we recommend an outside approach. So this is an example of a patient with a very large tumor. You can see on the ultrasound, this is a melanoma bulging from the back of the eye wall. And all this line here represents the retinal detachment, which is near total. So there's near total retinal detachment in this case. So here is another surgical video. Let me see if I can get this to play. Good. So the plaque is already in place, and this is a very large tumor, and all this on the outside is retinal detachment. We push it forward, and that arrow pointed to a needle that we place under the fluid, and we can suck out all that fluid so that the retina is completely flat, and then we can fill up the eye space with silicone oil. So we can maximize the benefit that silicone oil has to shield the radiation in eyes, particularly with large melanomas. So to summarize, we have good treatments for small melanomas, and we recommend that melanomas that are small undergo treatment in order to help minimize some of the side effect of the radiation and also for early treatment. We can remove the plaques, which is the source of the radiation that gets placed on the eye, in the office, so we don't have to have people come back to the operating room. And this is very beneficial, particularly for people who are older and for whom undergoing surgery can be potentially risky. And we can combine cataract surgery with our plaque treatments and some of the methods that we use here to help make things more convenient for the patient so that when they do develop cataract, so that they don't develop cataract afterwards, and also it helps optimize the purpose of doing the vitrectomy and doing the oil. And we've also shown an example of how we can treat the retinal detachment at the time that we treat our primary melanoma. So at this point, I'd welcome any questions, and thank you very much for your attention. So the first question is, what is the general prognosis for plaque therapy in treating ocular melanoma? So I look at prognosis as a multifaceted term. So first of all, prognosis for treating the tumor is usually very high. We can definitely kill the melanoma with using plaque. Now there is also visual prognosis. So how is the patient going to see? And that really depends on a number of factors. It depends on the size of the melanoma and where the melanoma is located. In general, the smaller the melanoma, the less amount of radiation that is needed to be generated by the plaque, and that results in the fewest potential side effects of the radiation. So a person with a very small melanoma undergoing plaque treatment, I would expect the prognosis to be quite good. However, a person with a very large melanoma needing a lot more radiation to treat it, the prognosis is more poor. However, if that melanoma is away from the center of the vision or away from the optic nerve, that person may do better, just given the location of the melanoma. And there's also general prognosis regarding mortality and this possible spread of the cancer elsewhere in the body. And in general, we've often felt that there was very little that we can do to actually alter a person's risk of mortality, because it was the biology that was present in the melanoma that may determine how a person does. But there is some newer evidence that perhaps very small melanomas, the treatment of small melanomas may be able to influence a person's development of metastatic disease. Now, the next question is, what is the normal recovery time for radiation plaque therapy? So, again, recovery time is, I'll break this into two parts. One is, when can a person start going about their regular activities and being out and about and walking around? Usually, even when the plaque is in place, a person can be mobile and even do mild physical exercise if they're comfortable. Sometimes there can be some discomfort, especially in the first few days after the surgery, and a person may prefer to rest. But if a person feels well the next day after surgery, they can probably do what they're normally used to with some caution. So we recommend in general, we don't do physical exertion or plan to do activities that you would normally do when you're feeling better. So the recovery time to doing activities is fairly short. Now there's also visual recovery time, and usually we feel that about a month or so after the treatment is where the vision will usually settle, because right after surgery a person may have very blurred vision just from having the operation and the inflammation and swelling that's involved. But after about a month, that should settle down, and a person will kind of go back to their baseline vision where we would expect. And of course, it depends on the tumor. It depends on what's done at the time of surgery. So the more that's done to address and treat the tumor, probably the longer the time that visual recovery will be. If it's a person with a very small tumor, which has a limited surgical procedure, that recovery time is going to be faster. And the third question here, can ocular melanoma tumor be surgically removed without radiation therapy or removing the eye? So the answer to this question is yes. Ocular melanoma can be removed without applying radiation or taking out the eye. And this has been explored decades ago, and people occasionally revisit old techniques. And after extensively reviewing the literature on this topic, my main concern was that there was a very high rate of tumor recurrence. So when we don't use the radiation and we try to debulk that tumor and leave the eye as is, the tumor often comes back. And there are some series that are published where the recurrence rate of the tumor returning is about 50%. So I think this is a topic that we may see emerging at various points in time, especially as surgical techniques evolve. But I would exercise caution, because when the tumor comes back in the eye, sometimes our standard treatments don't work anymore to try to control it. So here's a final question. I have a nevus in my left eye. How often should I get it checked? And can it turn into cancer? In general, if a person knows that they have a pigmented spot in their eye, I recommend that they do have that eye evaluated periodically and indefinitely. If the spot is very small or very flat with minimal features that suggest risk of transformation into a melanoma, that person might be followed every year or every couple of years. Much of this depends on the characteristics of the nevus. There are some nevi that are large and elevated that have what we call sort of risky features associated with them. And a person who has something that is more of a suspicious nevus as opposed to a flat appearing benign nevus, that person we would recommend that they get more close follow-up for their lesion. So in our practice in general, when people have an elevated nevus, I recommend they get checked twice a year. But for many people with the flat freckle in their eye, yearly or every 2 years evaluation is important. And certainly it must be remembered that if a person has any sort of new symptom in their eye, that they get that evaluated. And the question is, can it turn into cancer? Even a flat nevus, although rare, can turn and transform into a melanoma and start to grow. Similarly, when we think of freckles on your skin, many times these freckles stay with us and don't do much for our lives. But occasionally a freckle may start to look a little different and actually start to turn into melanoma. In the eye, it's very similar. All right, thank you very much for your attention.